Osteopathic case study, 27-year-old male presenting the clinic with non-specific low back pain with no referral to the legs. Now this is a great case because we see these patients all the time, and it's our ability to make the difference with these patients that really is going to take your practice forward so that you have a thriving practice, or we kind of just bump along doing some good work, which is okay, but we don't enjoy the full riches that osteopathy can bring to us and bring to our patients. Now there's always more to learn with osteopathy, so I'm certainly not saying that I've got all the answers, but what I'd like to do in this video is really give you the benefit of my many years experience working with these type of patients. Because when you first start off, these patients are kind of easy when they first come in. Oh, just this going on, there's no disc injury, there's no imaging to show there's a real problem. But when you get into it, it's like you can't seem to make the difference for that patient. And even though the patient's symptoms are not that bad, they don't have raging pain down the leg, for them it's really important. And if you don't make the difference with them, then they don't come back and they don't refer other people in to see you. So these are the cases that are important to make the difference with, because we see a lot of them, but also because as you see as we go through this actual video and go through this case history, examination, treatment, as I walk you through it, you'll see the thought processes and you'll see the structure that if we apply that to our patients, then even when we don't nail it first time, the next time you have a patient like that, or the next time after that, each time you're growing and you're understanding more about the processes, and it's not a hit and miss kind of thing. It's not like, oh right, that person was great and this other person wasn't, and you're not really sure the difference. Why? Well, I kind of did this, and then that one, I kind of did the same, but it wasn't the same response. And so in this video, that's what it's all about. It's trying to give you the processes and the insights so that you really can build a difference with your patient and make a bigger difference, so that each time you go in the clinic, you're getting better and better, and you really fast track your skills and fast track the growth of your practice. Okay, so let's get into this case study. And of course, it starts with history. He's had this back pain for a very long time. How long it's been there? Forever. What caused it? Oh, I don't really know. And you get these cases and it's like, well, okay, that doesn't really give me much to go on. But with the first pass, if you start trying to nail them on that one, okay, well, there must be a cause, and how long, and you know, what happens then is that you just annoy them. You just annoy them. So at the first pass, you let that go. Okay, low back pain, no referral into the legs, just stuck in that low back, more on the left hand side. It's been there forever, doesn't really know what's caused it. And so you move on, and you move on into that previous history, and you ask them about the previous history. Now in this case, first thing that came up, there's a few kind of sports injury, but there was a big major car accident at 17 years old, so about 10 years ago. And so we asked more about that. And what happened, the car was T-boned from the side. This person was driving, ended up in hospital, fractured ribs, punctured lung, pretty serious, was in hospital for over a week. That's immediately light bulbs go up. Okay, right, well this has probably affected the body pretty strongly and may well be the cause of this low back pain. But we don't immediately say that. We don't say, oh, well, did you get the back pain straight away? Because if they're not offering that, then it's likely that we're trying to lead them a little bit. And so we just let them go through the rest of the history. Wasn't anything else there in previous history, which again kind of highlights that one thing that we picked up. And system's completely clear. This is a 27-year-old that is very healthy, other than this low back pain, does a lot of sport, a lot of energy, really nice guy, comes over very personally. There doesn't appear to be any history of anxiety or depression or anything like that. Nice guy, good energy, but this low back pain is really affecting his quality of life. So once we run through that, now's the time to come back and go a little bit harder in that second tranche of the history. And so you say to him, okay, well, it's been there forever. I just want to nail that down a little bit more. And the way to do that is to pick up on life events. So, for example, remember when you got married, was it there? Remember when you had your first child, was it there then? Those sort of things. Now, in this case, the obvious one is to say, okay, well, I'll take you back to when you were in school. Did you have it then? And the answer is, no, he doesn't. Okay, and what age did you leave school? 18. Okay, so we got a car accident at 17, and we got leaving school like about a year later, and he doesn't report any low back pain at that time. There's something going on from 18 to where we are now that he's missed and hasn't told us, or is it that car injury, because that was pretty big, and over time there's been a decompensation through the system, and that's loaded the back up, And because he's active and he's doing stuff in the gym, he's doing sports, the low back hasn't been able to cope with it. And that was my first thoughts, but we just park it there. We just think, okay, that's what I think, but now we're going to go on and do the examination, because that's going to clue us in more. And as we get the palpation and we get the feedback from that examination, not only do we get that information, but it allows us to ask a little bit more about the history. So sometimes you can push too hard with the history. You're trying to nail that etiology, that cause, that onset. What was the day that happened? But sometimes it's good to have that first go, second go, and then leave it, and then we're going to progress a bit more through the history as we do the examination and as we do the treatment. So it's a cycler type of thing, a cycle through this. So on to examination. I get the man to stand up, and we're going to do the drop hip test, where we just get them to stand there and say, drop your right knee, okay, back up, drop the left knee. And whilst we're doing that, we've asked them, is any pain or discomfort? Now there's pain on his right hip drop in his left SIJ area in towards that low back. So you always got to be specific and ask where that pain actually is. When he drops the left hand side, no pain at all. Now in terms of movement, because my hands are on there palpating, there's no particular difference in movement there. The range is fine. So the next thing we do is we get him to bend forward towards his toes, get them to drop their head in first and go slowly. And you don't want to say touch your toes, because they fire over there and they can hurt their low back. So you say drop your head forward and then bend forward towards your toes. Don't go any further than you feel comfortable. So this is sometimes called the standard flexion test. And at that point you've got your hands on the SIJ area and around the innominate, feeling for movement. Now as he goes down and back up, he doesn't say anything. And this is classic. So you say to him, is there any pain? He goes, oh yeah, there was. You think the patient would tell you, but no, not always. Is there any pain? Yeah, there was a little bit going down, more on coming up. Where's the pain? Again, in that SIJ, over on that left-hand side, spanning in towards the lumbosacral junction. Now, in terms of actual what we're moving and was happening, as he did that, we're expecting the innominates, where we're feeling, we're expecting that anterior motion. Now, what happens there is the right one goes, and the left one goes a little bit, but doesn't go as much. So there's telling us there's something going on in the pelvis. We park that there, just hold that bit of information, and we move on to the next part of our examination. So I did a screen as well where we were standing, but there was nothing remarkable in that. Next thing, we lie him down supine, so face up towards the ceiling. And I come in and I look at leg length. Leg length is absolutely fine, no problem with there whatsoever. I do a quick screen of ankles and of knees and of hips, just to see what's going on there. No particular big problem. Now I'm doing that in terms of, I've just got him to supine, so I take hold of the ankle, move the foot up into dorsiflexion, testing what's going on with the talus, range of motion, take hold of the patella, move the patellas to see if there's much movement there. That's often a good screen. If you can move the patella either way quite easily, and it is equal on each side, it's a nice screen, very quick, no major problems there in the knee. It's not a full examination, just a screen. Up on the hips, I put my hand over the innominate on one side, and I just put some weight down it. So I'm shearing that SIJ at the back, and it's also moving that innominate. Now on the right hand side, he's reporting pain in his right SIJ. On the left hand side, nothing at all. Now this is different to what's happening in the back, and at these points is when you start to go, oh hang on, this doesn't fit, I'm getting confused. Especially if you just come out of college, just graduated, you're trying to fit this all in, you're trying to, you've already got a few things in your mind about what the diagnosis might be, and so you're trying to put all these clues together to fit one of them. And when you get a little bit of, it's not really a curveball, but when you get something like this that perhaps doesn't agree, it's like, oh hang on, left SIJ pain when we had him in the standing test, now I've got him lying down and I compress with that left SIJ and I shear it and it's fine, but the right one has pain, it kind of throws you a bit, and it kind of, you start getting crosses through some of your diagnosis, or you just get a little bit, whoa, okay, that doesn't fit the pattern. And then as you get more and more things that don't fit the pattern, the more you tend to get up in your head and get a little bit confused because you're not quite sure what's going on. And then when you move to treatment, you end up doing this kind of non-specific global treatment that perhaps isn't as targeted as it could be, and so you don't get the results you want. So it's important at this stage is if you get what you're doing with these bits of information is you're just, and I don't write any of this down, if you're used to going to write it down, come exam and going to write it down, I encourage you not to do that. 2 reasons. One, it slows you down. 3 reasons actually. 1, it slows you down. 2, you don't need to. The information is in your hands. And when you come to treatment, the information is already there, even if you can't bring it to your conscious mind. But it is in your conscious mind anyway. And that's the 3rd reason, is that you will be able to come back to this and remember it, because you're not in the pressure of an exam. It's not like the examiner put you on the spotlight and say, oh, X, Y, and Z. What happens is you're building a picture and getting more and more information, and the information will come back to you at the point you need it in the exam and treatment. And if it's not there instantaneously, well, it'll come back a minute later, because the patient isn't going to be quizzing you like, well, hang on, why is this and why is that? And if they are, you just say, at this stage, we're just collecting information, we're not jumping to conclusions, that's not going to help us. And that's essentially the message here. You don't jump to conclusion. You're just collecting different pieces of information that's going up into your brain and in your hands, and you're not jumping to conclusions. And at the end, it will all come together. Trust me, it will all come together to give you what you need to make the treatment. Even if you can't, in your mind, write down what this actual working diagnosis is. As long as you're safe to treat, and as long as you've been collecting good information and had a good examination, the treatment will go well. So, back to our examination. After I did that test on the anomaly and the SIJs, then I brought the hips up into flexion a little bit, and I just did a little screen of the hips. And there was a lot of tension through the right psoas and the right rectus femoris, but the hip joint itself was working fine, which gives me a nice kind of screen of that lower screen. And I don't think there's a lot of stuff coming from the lower limb pushing up into the pelvis. So I'm thinking the problem is in the pelvis or higher. Now, it's not categoric, but you have to make these decisions, and that's why we do screens. Screens are to pick up, bad stuff and things like, oh my God, I need to red flag refer this person. But it's also to say, okay, well, for the moment, I can just push that to a side for one moment. I'm not ruling it out, but I'm saying I'm not going to pay as much attention to that while I hone in on some of the other areas. Because we literally do not have enough time to do orthopedic testing and all the other testing that we need to do and palpate the whole body. You're just going to have a 2-hour examination, patient's going to get frustrated, you get no treatment and they don't come back. So after that screen, we move up the body because that's where we feel we want to pay a little bit more attention. And with a patient in the supine position, I want to know what's going on with the thorax and the rib cage, because we've had that old car injury. And we were told about this impact. We're told about the influence on the lung, injury to the lung, and also upper right hand side, 3 or 4 fractured ribs. So that's an area we want to look at. And what we do, we put the hands either side of the rib cage, not right high up, kind of reasonably mid to low rib cage, and I do a shear to one side and a shear back the other way. I want to see how that whole rib cage is moving, and definitely big difference. When we go one way towards that right hand side, good movement. When we move towards the left, it doesn't move. There's this holding through the right rib cage. I then place my hand on the sternum and 2 hands, and I do a rotation one way and rotation other way. I want to see what's happening with that sternum. And again, we see a big difference. We see this clockwise motion, rotation into the right hand side of the sternum. It's okay with that. Not brilliant, but it's okay. And on that left hand way, go into that anti-clockwise towards that left. It doesn't like it at all. It's really holding. So I know that there's a lot of, even just with the screen, that there's a lot of holding in that area. Now that ties in really nicely with that car accident in terms of what happened there, a major incident that we got in the history, and he didn't get a lot of treatment for that afterwards. So I know from this screen that there's still stuff going on in this upper thorax, and that's really significant because he's had that for 10 years now, and that is going to clue in with our possible working diagnosis that we were thinking about earlier of decompensation. A decompensation pattern through the body influences this low back. Now that's quite non-specific, but hey, we're only like 5 minutes into the examination, that's fine. It's just like a little thought pattern. Go, decompensation, a little bit more, one more vote, tick for that. But we're not saying that's for sure. We're just gonna go on now with our examination. And so at this stage, what I do is I turn him over because I want to get more specific in the low back and the pelvis and those lower lumbars. Because yes, we got this thing going on the thorax, but we also know there's something going on with SIJ joint and pelvis because of our previous finding. We had him standing and also when we had him supine, and we're doing that shear test through that SIJ. So the first thing I do with that examination is I place my hand on sacrum, one hand like this, other hand on top. The bottom hand is gentle and passive, not doing a lot, it's just feeling. The top hand is going to do the motion. And then I rotate the sacrum one way and I rotate the sacrum the other way. And then I do a shear to the sacrum one way and I do a shear with the sacrum to the other way. You always do the rotation first because that's less provocative for the pelvis. If you're doing that and they're getting pain, you may not want to go on and do that shear from side to side. Now when we do that with him, there's a difference on either side, and that's something that we're looking for. And what we can do is we can, in a person where it's working well, and it's different, age groups, because obviously a 17-year-old to a 70-year-old is going to have more range of motion through there. Women generally have a little bit more motion through there than men. There's these different things. But generally what you're looking for is, if this is midnight, I put it up in front of my face, then you're looking for 10 past and 10 to midnight. That's roughly where you're going to. And in some people you find, my God, one side it goes to 2 minutes to, and the other side it goes to 2 minutes to or nothing at all. It's like nothing at all. So, oh my God, that's completely stuck. But in a lot of patients, what you'll find is that you get a good range of motion to one side and then you don't to the other side. And that's actually what happened in this patient. And so that's telling you partly that there's probably a shift to the sacrum, but also is the whole influence is through the low back in terms of the mechanics of the L5, what may be going on with the viscera, what may be going on with the innominate, the rectus spinae, the lat muscles which attach into the sacrum. All of those could be implicated in what's going on here. So it's not like you do this and you go, oh, X has happened. But what you're saying is, aha, definitely this sacrum is not doing what we want it to do, and that could be causing the pain. If you think about the sacrum and it's not able to move properly, and then the person's moving and doing activity, then what is going to be happening between the sacrum and the L5? The mechanics are not going to be doing as well as they wanted to do. And that's why after you've done that test, you move on and you start testing the specific vertebra. Now at this stage, what you can just do is just press into each SP just to see if they're tender or not. In this case, they weren't. And that also will clue you in to any depth there. So if you've got a lordosis, a hyperlordosis or spondylolisthesis, you want to really be able to suss that straight away. And in this case, there wasn't at all. What we did find though is that the lordosis there's a little bit of a deeper lordosis in that lower lumbars, a kind of localized lordosis there. And as we come up towards the upper lumbars and the thoracolumbar junction, there isn't much lordosis. There's a hypo at the top and a hyper at the bottom. And again, with different patients, you see different things come through and different ranges from hyper to hypo. And as you work with that, you get more experience, you understand what's normal and what's not. But what definitely isn't normal, or isn't, should we say functional, is probably a better word, is when you get these localized things where it's like this deeper lordosis in these 2 or 3 segments, and this much shallower lordosis is hyperlordosis in these other segments further up. Now what's happening there is that you're getting these compensations. So what we want is that gradual lordosis over that whole range of the lumbars. And if you're not getting that, then it's telling you that the body has had to do things to cope with what's happened to it. Now, we can't jump to conclusions and say, oh, the hyperlordosis is causing the hypo up here, or the hypo up here is causing the hyper down there. We again just park that information. It's good information. We park that information, and it adds a little bit to that decompensation theory that we're thinking about, and we'll come back and put all these pieces of the puzzle together at a later date. Now at this stage of our examination, what you can do is specifically get in on each single vertebra and try to ascertain whether it's side bending, flexed, rotated, side shifted. And there are people that do that, and if you do that, great, I'm not knocking that at all. But at this stage, I like to avoid that. And the reason that being is because it can be a little bit provocative for the patient, but also it tends to, for me anyway, and you just have to make your own judgment on this, it tends to get me too specific into a particular joint. It's like, oh, that L5 has done this and this and this and this. And it really hones my mind on the L5. And at this stage, I still want to be a little bit broad stroke. And that's why I'll explain the next test that I do, or the next motion test that I do. And I want to keep my brain and mind open, allowing me all the possibilities of what's happening to this whole low back, this whole pelvis, this whole body, rather than get too micro at this stage. You can always get micro later on. And the difficulty is that not only can you get micro and your mind gets a bit locked in, when you get really kind of minutiae with a vertebra like that, the body, their patient responds to that because they're always responding to your hands on them in a physical way, but also in an energetic way, and showing you what you're asking to see. And this is why inter-examination reliability is rubbish. So they'll do studies of osteopathy and other manual therapies and go, well, it's all a lot of rubbish, because what happens is when we have this patient and we get examiner A to see what's going on and tell us, and examiner B and C, they all report different things. Now, there's lots of reasons for that, skills, experience, etc., etc. But also because what happens is the body is this living entity, and it is super clever. And what happens is when you put your hand on a patient, the body goes, oh, this person is really good at X. And this person really likes working with Y. So I'm going to show them X and Y. You know, like the problems in the fascia, or the structural, what's happening with the bones, or what's happening with the muscles, or what's happening with the nervous system, or the viscera, or whatever. And so this is why you get different tests between different people when they examine. And so what happens is your intent and what you're focused on narrows your view, but it also doubles that because the patient body fires back at you what you're asking to see. Now that is a good thing and a bad thing, because it's a great thing if you take hold of a leg, for example, at the foot, and you do a little leg tug, just to test what's going on through the knee and the hip. Now if you get specific and think bones, and you tug on the knee, really focus on the hip bone, the body shows you and you're focusing on what's going on with the hip. And you get a really good view of that hip bone and what's happening in terms of that joint. Now, if you change your focus and you go, I'm more interested in the whole fascial connection up through the whole body, and you pull on that hip, then of course there's a slightly different feel to what you're doing, but the body responds and shows you that whole thing. And you're less information from the hip, and you get this more fascial kind of readback from the body. And so that's a really important thing to know. And so when you're working with patients, dial your focus in and dial it back out depending on what you want to find out. So at this stage, I don't like to dial in too much to the vertebra because of what we just said. And what I'll do instead is I'll take a broad motion testing to the lumbars. And I put one hand up on the thoracolumbar junction, and I put one hand around the pelvis so I can rock the pelvis, and I'll rock that pelvis and I'll work down the vertebrae with my thumb, feeling what's going on in terms of the movement of each one. And that enables me to be specific to each vertebra without being too specific. But it also at the same time, let's say we're at L3, feeling what's going on at L3, I still get a sense of what's happening through the rest of the vertebra, even all the way up to the spine. You turn over, you go to the other side, and then you put your hand on the DL, thoracolumbar junction, and you work from the other side. And so now you get a general specific, if we can use that, of each vertebra, and a generalized of what's going on through the whole lumbars and thoracic spine on one side, come onto the other and see the other side. It was really clear what was going on, is that when we had this rotation, whichever way this is, pelvis, this way, so I'm standing on the left of the patient, this worked nicely, moved on to the other side, and it didn't work well at all. And what's great about this is that the patients can feel that. They can really, because when you press on the vertebra, it might be sore, but they can't tell if it's side bent or side rotated, whatever. But when you do this global thing, they go, yeah, they can really feel, because it's the same kind of stretch you do where you go, oh, okay, yeah, that works really nicely, and it's like, oh, a bit stiff this way. So they can really feel it, and it's a great feedback for them. And, of course, it's great information for us. And so when I did that, there was a clear thing that was going on. And so what we're doing is, and it's a little bit hard to build a picture on the visually for you with the words because you're not there with the patient. But now what we got is we've got sacrum, we've got something going on with the SIJ joints because we picked one up left when they're standing, one on the right when they were supine in the testing. We've got the thorax, something going on through there. And now when we try to do this global movement, moving their whole spine, we've got a big difference left to right. Now at this stage, I'm reasonably confident that we've got this decompensation pattern running down through the body, and that the initial injury, because we've got nothing else in the history, and as I'm working through the different points, I say, well, have you had an injury in this area before? No. So we're clearing through that history, and I'm reasonably confident at this stage that we've got a decompensation pattern initially caused by the injury through the trauma of the car accident that over time had built up and caused a problem for this low back, which now means we've got mechanical restrictions and decompensations through the sacrum, through both SIJ joints and through the lumbars. Now, with the hypo and the hyperlordosis, perhaps they were there before the car accident. We don't know. Perhaps they were developmental. He's a tall man, so perhaps that's part of what that's going on. But look, we can't control those things, and we don't try and look to jump to conclusions we don't know them. We park that for 1 minute and we move on to the next stuff. But now what we have is enough information to go on towards treatment. Really, I feel that we can move on and do that even if we don't know absolutely everything. The key thing here is, are we safe to treat? Yes. Do we have a direction to go in? And I would say, yes, we do. Now, we might change direction. We might, as we treat and do mini examinations and get feedback from what's happening with the treatment and the response from the body, go, okay, we need to adjust here a little bit, change direction, or even change direction completely. Point at this moment is, are we safe? Yes. Can we continue with the direction toward treatment? Yes. So that's what we do. We get in and we treat. Now, as we move into this treatment section of the video, I want to split this into two parts. The first part is where we're going to treat, and the second part is how we're going to treat. And the reason being is that the how bit can vary from practitioner to practitioner. So you might be similar to style to me, but you might not, in which case you want to know where we're going to treat and why we chose those areas, so you can still apply that to your patients, even if you vary in the actual techniques that you use in terms of treatment. So, in terms of treatment, where do I start? I'm going to start at the pelvis. Two reasons for that. One is that, when I talk about pelvis and low back, that is the patient's area of complaint, so they're going to be happy if we start there. The second one is I want to try to ascertain if I can get a shift quickly in that sacrum. Remember, we did that rotation and the side shift, and it wasn't equal on either side. So I want to see if I can get a quick change for that. And so it's a little bit of one of my go-tos. And so that's where we're going to start. And then we're going to move on to that thorax area around the ribs, because I want to see if we can get a change through there, because I think, I don't know, but I think this is a major part of that, and this came first before we had the decompensations into the low back. So what I do in terms of treatment, I have the patient prone at this stage, and what I'll do is I'll put one hand on the sacrum and I'll slide one hand across the kind of the belly, the low belly, in line with the innominate. And so if you like, my hand, this part of my hand is in one area where the rectus femoris is, psoas kind of area, and the other fingers across the other end. So his line on top of me here, and my hand is underneath. And what I do is put one hand on the sacrum and I just engage and wait. So it's a functional style treatment. It's engaging the muscles in that area, but really listening to what's going on with the nervous system, listening for feedback, a little bit of pushing in. So there's a little bit of inhibition, but not in a kind of torture in the area. I'm trying to create a little bit of compression to get the place to respond, to wake up, and to recognize I'm there. And then I'm going to back off a little bit and listen. And when I do that, that area actually starts to soften quite a lot. And there's a lot of tension, which I didn't mention in the examination, I should have done, a lot of tension in the right rectus femoris and the right psoas. So I'm just trying to engage that area and get that area to just soften and let go. And it's surprising how quickly that will happen if you're in the right area, because that area doesn't really want to hold tight. It's holding tight because of the whole decompensation pattern. And when I give it the opportunity, provide a fulcrum, a balance point for it to shift, often it'll go, oh, great, somebody's come along to help me, someone has come along to give me a little bit of relief and take some of the load off me. I'm just going to take 5 minutes and park all the work I've been doing and just relax. Relaxes. Now, of course, you can't leave the treatment there, and if you let the patient go out, the whole thing will fire up again. But we're trying to create slack in the system to enable us to get more done, and we're also trying to see if that responds, to see if we get a response with the sacrum. And then I did that on the left-hand side as well, so I swapped over, so I was targeting the left-hand rec fem and psoas. And I'll just an aside here, yes, you're working those areas, rectus femoris, psoas, but you're also engaging the whole abdominal wall, the whole pelvic floor at the same time. It's an entry point. And when I did that and I came back and I retested that, we had a really big change. They weren't even on either side, but there was a significant change. Now, if it's changed that quickly with that type of treatment, because I haven't gone trying to shove something over the, mechanically move something, just with that little bit of treatment, we get the change through the nervous system, through the softening of the area through there, and the sacrum shifts, then I know there isn't a major problem with the sacrum and the L5. The mechanics there are responding to what else is going on with the body because the change has been so quickly. And so what happens then is I then turned the patient over and I came up and I started to work on that thorax area. And again, I just want to give you those locations. So I'm working on that pelvic floor, work on the rectum and psoas into the sacrum to try and get some shift there. So that's your first target. You may choose different techniques to do that. You could have them supine and you could work in an MET, trying to work that rec fem free, other techniques to work the psoas free. You could work some visceral techniques into there, into the lower mesentery, abdomen in that area. Lots of different techniques you could use. I wouldn't go straight at the sacrum because, as we said, we think there's a little bit of the sacrum responding, but even if you did, it wouldn't actually probably do much harm. You wouldn't want to use a really strong HVT or something like that, but an MET through that area, something like that, getting some change, and you probably would lead you, wouldn't get as much change as we did the direction I did it, but it leads you into some change. It would probably lead you into thinking, oh, okay, maybe I need to work rec femoris psoas. So that's that kind of area to treat first, area 1. Area 2 then, and this is an important point, is I come up and work on the thorax and the rib cage on that right hand side where that trauma was. And I want to get in to this past trauma, and I will shoot a second video specifically about what I did here, somato-emotional release, past trauma, retained trauma in the body, because this video is getting long and we need a whole video just to explain that. But I put my hands on there and I asked him very gently, and I engaged that area, and I asked him to tell me about the car accident. And as he talked through the car accident, I was thinking about, okay, well, the force would have come in there, so that would have happened, and that rib got fractured, and there was the influence on the lung, and the whole thing started to shift. There was a huge shift through the system. His breathing changed. He had a somato-emotional release. There was a release of the retained trauma in that area, a big shift. And I will split that out in a separate video and go into detail on somato-emotional release and those things. But that shift, once I got that, I then retested through the side shift through the thorax, the rib cage, through that rotation for the sternum, and we got a big change through there again. Now, if you hadn't got that change, I know there's more work to do, or the techniques I was doing through there hadn't responded. So, for example, you might come up and work on that area and not know any somato-emotional release and want to be more mechanical, nothing wrong with that, and you might spring the rib cage or try and do some work to free up that rib cage because you can feel it stuck. You then retest, it's actually not changed. In fact, it might even be worse. It's cluing you in then that you are in the right area and working on the right part of the car. It's just you've got the wrong tool. You need to put the spanner down and get something else out instead. Now, you may not, if you're early in your career, have the actual tool that you need, but that doesn't matter so much. It maybe matters for that patient, okay, but you're still in that learning phase. But long term, what I want you to do is recognize that. Go, I was at the right area, at the right time, the right sequence in the treatment, but I just didn't quite have the right tool or the right skill set in that I only use this tool 1 or 2 times. And it's hard to work that out, but if you're good with the timing, good with the sequencing, working on the right spot, you will get change, even if you don't get the change you want to, and it will allow you to progress with your osteopathy and identify if there's a gap in your skill set where you need to go off and get training. We need to go off and get a different tool. And that's really important to know, rather than not knowing why it didn't respond, not knowing why you didn't get the response for the treatment, and then kind of floundering a little bit and doing the same thing over and over again, perhaps for the next 10, 15, 20 years. Doesn't mean you can't be a good osteopath, but we don't want you to be a good osteopath. We want you to be a great osteopath and making a real difference in the world and really, putting your soul into this work and getting the riches that you can out of it. So that's what I want to make that little aside there. Okay, so we worked on the pelvis and we worked through that rec fem and psoas area through there, and we worked on the thorax and the rib cage. Where do we go next? Well, next I turn the patient prone again, and I do that testing that we talked about earlier. I want to retest and see if that motion through all of the lumbar spine on the one side and then on the other is working well. And when we do that, it has responded really well. It's probably 50 to 60% better. Now at this stage, that's probably a good treatment. You could go with that. You could just go with that. There's been a big shift for the patient. However, if you hadn't got as big a shift in the thorax with a somato-emotional change, then we are going to have to work a little bit more mechanically through these lumbars, and that's actually what I chose to do at this point anyway. I just wanted to get more change. And so I did exactly the same thing here, but now instead of palpating, now I'm starting to work those lumbars a little bit more, a little bit mobilization from the DL junction all the way down to L5 on either side. Then I came back, examined the rotation for the sacrum again, and see if there's anything I needed to do, whether I needed to do a sacral toggle or not. I decided there wasn't. I just came back, I turned the patient over, and I came back and I did some work to the rectus femoris and psoas on either side, working the hips a little bit more, and then retested that shear test that we did in the supine examination onto that right SI, and there wasn't any pain, no pain through the right SI joint. So I'm thinking, okay, we're probably done here. I sit the patient up, I stand him up, and this is the moment of truth. I want to do those tests that we did at the start. Now there's a temptation to maybe fudge it and think, oh, okay, let the patient go. You need to know for your library of information, your experience and your progression as osteopath, how far you've got. So face that moment of truth, and we get him to do that drop hip test on either side. And I don't know at this stage whether he's going to get pain or not. And if he gets pain, it isn't a bad treatment. I know I've given a good treatment, but I want to really know how good a treatment it is, because we can always get better. But when he did this thing, there was no pain. And I'm like, hey, that's good. And the great thing about doing that retest for the patient is if there's no pain, he's like, whoa, great. But even if there is pain, you don't go, oh. You don't sag, you go, okay, great, I want to do that test because I want to see how much pain there is there, and there's still pain there, and that's fine. So that tells me I want you to do X, Y, and Z, and I don't want you to do, because this guy does a lot of stuff in the gym, I don't want you to do anything in the gym. So it enables you also to hone your post-treatment in terms of what you want them to do and not do. So we did that test, and then we did the standing flexion test, the bending forward and back, and on this one he did have pain, not as much before, about 50%. So I'm happy with that, but it also gives me the gauge of telling him, and I was glad there was a bit of pain there, because if there's no pain, it's going to be hard for me to convince him to stay out of the gym. Because there's a bit of pain, I can use that and say, okay, the body's still changing, I want you to be very careful with that today. You can go and do lots of walking and swimming and things like that, but nothing in the gym. And he's like, nothing in the gym, because he liked to do the gym. And nothing in the gym, a little bit of, and that's when we had, can I do swimming? Yeah. Can I do this? Yeah. Can I do cycling? I said, yeah, you can. Yeah, so you're specific on what they can do and what they can't do. You don't want them going out and breaking it, and sometimes when they're a lot better, that can be really dangerous. They're like, wow, I feel so good. They haven't been able to mow the lawn or do different stuff. Suddenly they're doing 1,000 bits of DIY, and they come in pieces the next week. You don't want that. Okay, so that's a treatment, and I will also shoot another video on that somato-emotional release and trauma, past trauma that's retained in the body. If you like the video, please hit the like button and subscribe. It helps me know to do more cases like this.